afternoon, everyone. Welcome to this AM Upskills webinar. My name is Georgia Seago. I'm editor of Aesthetic Medicine, and I'm joined this afternoon by the lovely Dr. Catharine Denning. Hi, Catharine.
Hello there. How are you doing?
Thank you so much for joining us.
It's my pleasure.
So we are going to be talking this afternoon about treating lockdown face. And I'm going to be asking Catharine about her predictions for the sorts of treatments that you guys can expect to see a lot of demand for when you open up again next month in clinic. And also her approach to treating some of the really kind of common indications that we're seeing from people having been sort of locked up on and off for the last year. So while everyone joins, if you've got any questions during the session, if you just pop them in the chat box, then I will ask Catharine all your questions at the end. And we've got a few images to show, but for the most part, I think we're just going to kind of have a chat, aren't we? So, Catharine, do you want to just introduce yourself a little bit to us, please?
Yeah, sure. So my name is Dr. Catharine Denning. I am an aesthetics doctor, and I've been doing that full time now for several years. I run a clinic on Wimpole Street called Clinic 1.6, of which I am the clinical director. So I'm seeing, not currently obviously, but pre-lockdown, I'm seeing patients every single day, a really diverse range of ages, ethnicities. So yeah, so I'm excited to give my 2 cents worth, I guess, on what I think post-lockdown treatments will look like for everybody.
Yeah, so you actually wrote an article for us in the March issue of the magazine, which was all about this. And I know there was a gap between our first lockdown where everything kind of briefly opened up again and you were able to see patients. So what did you kind of notice during that time from when, after the first lockdown, where you were able to see people again? Like, what kind of things were people presenting with to do with lockdown?
Yeah, so it's a good question, because I've definitely noticed over the last year just common themes from all my patients, from men and women, in fact, and all ages. I guess the most common thing that people are requesting or asking about or complaining of is looking tired. So sort of around the eye area, people are worried about things like eye bags, the palpable malar groove being more obvious, particularly because, you know, they're on Zoom calls a lot, so they're noticing their faces on different angles and in different lights. And I think people are wearing more masks, and so they're expressing themselves a lot more with their eyes, and they're noticing themselves a lot more with their eyes. So eyes has been a really, really big one that I've noticed, and it's always been popular in my clinic. I'd say it's one of the more popular, particularly filler related presentations that I see, but it's definitely much more. Younger people are presenting with it, and I'm seeing much more men actually coming in and worrying about their eye area. Eyes, I'd say, is the first one. The second one's probably jawline and sort of submental area. I guess again on Zoom calls, they're sort of seeing their profile probably a little more than they're used to, and tilting over laptops and things like that. They're just noticing a lack of definition in the jawline, and maybe some exacerbation of submental fat, all those lockdown takeaways, less exercise, maybe, I don't know. And that's another thing that people are that the neck, and it's a common problem anyway. It's sort of the coined term tech neck obviously comes from people bending over laptops, mobiles. You know, we're constantly kind of looking down all the time, aren't we, at a screen? So people noticing skin laxity in the neck, but also the sort of necklace lines are becoming much more a thing that people are reaching out to have help with. And unusually, actually, something that I wrote about in the article as well, but unusually, and something I didn't really predict, was people coming in about their hands, interestingly, in terms of aging of the skin of the hands. And I'm guessing it's because they're doing a lot more hand washing, they're noticing their hands a lot more. Perhaps, you know, at home they've got more time to kind of, as they type on their computer, notice the aging of their hands. I'm not sure why, they're noticing it more, but they seem to be. And so sort of aging of the hands is another thing that I've noticed a lot more of, which was, you know, something that I did before lockdown and before the pandemic, but I'm definitely noticing an uptake in it of late. So yeah.
Mm. And are you noticing more like first-time patients for aesthetic treatments as opposed to you know, people you've treated before or who have had aesthetic treatments elsewhere?
Yeah, a mixture of both, to be honest. I mean, I have a good loyal patient base anyway, you know, that I see several times a year. So I'm continuing to keep up with them, and they're continuing to come in for their regular treatments. And I'm noticing that they're asking for like other treatments, such as, you know, periorbital rejuvenation or worrying more about their neck, whereas before they'd only be coming in for, let's say, through area Botox. And I'm definitely finding that newer patients coming through that have never even sort of thought about aesthetic treatments are reaching out and finding out kind of, you know, what's available to them, what results can they expect to have, you know, how much is it going to cost them, that sort of stuff. And I think it's, you know, when we're able to open clinic doors again in April, I think I'm definitely going to see a lot more sort of first time aesthetic patients. I think we've had a lot of inquiries. So yeah, it's interesting. And I think because, like I said, people are spending lots of time looking at themselves on Zoom calls, and they're spending a lot more time at home. So, you know, they are able to just look in the mirror a bit more and notice things about their face that they perhaps that perhaps worries them. I think, you know, the pandemic's aged everybody. We've all been stressed. You know, we know that cortisol plays a big part in the aging process. And as a result, I think people have noticed that acceleration in the aging process, so are reaching out a little bit more.
So then thinking about like the specific treatments and the way that you would actually approach these sorts of indications in someone, if we start with the upper third, what would your kind of what would you be looking at initially with this kind of patient?
Yeah, so like, I mean, my approach, as you know, Georgia, is I'm quite systematic in the ways that I review patients. So taking a really good history and understanding exactly what it is that bothers someone's actually really important. So and that goes for any third of the face. And then the other thing that I think is really important with anything that you're treating is to treat holistically. You know, not just talk about what we're going to be doing in clinic, for instance, but also how can you diet, exercise, you know, skincare is really important. So sort of starting with the basics and then approaching the actual physical examination in a really systematic way. And I like to start top to bottom, and I split the face into thirds. I think it's quite a common way that people examine the face, but as long as you've got some form of systematic approach, I think that's the important thing, so you don't miss anything. But the upper third, I think the most popular thing that I get asked for is botulinum toxin injections into the frontalis and into the glabella region, obviously. It's an area that I think you have to be very selective, actually, for you know, rhytids in the forehead are they're difficult to treat once they are present and they are at resting. You know, they're present at rest, and I think using simple sort of skincare and in clinic kind of non-botulinum toxin treatments are just as important, and sometimes, in fact, with botulinum toxin, I personally, I try and avoid treating the frontalis where possible with botulinum toxin, because we know that the long-term effects of reducing that muscle strength can flatten eyebrows, particularly in females, which obviously gives a really undesired result in females as they get older, and they lose that sort of lift from from the natural action of the frontalis. You know, we know that now long-term botulinum toxin use accelerates that sort of drop of the brow. So, you know, I am selective in who I treat for that. I try to do lots of skin treatments, things like needling, radiofrequency, skin boosters where possible. You know, rather than just rely on toxin treatments. And I think that is a general, I think a lot of people are finding that now. A lot of practitioners are finding that that the upper third actually, we're relying less on those sort of quick fixes like botulinum toxin, and actually treating the skin and just sort of thinking a little bit more holistically about it, I guess. Yeah, so upper third, you know, it is a concern for people. But I think sort of lockdown wise, it's not been something I've been seeing an uptake in necessarily compared to other areas. You know, if you move on to the sorry, did you have any questions about the upper third? And then otherwise I'll move down to the middle third, I think.
I was just going to say, it's interesting thinking about, you know, what do these complaints actually look like on the face, because I think if someone says that they feel like they look tired, you would automatically think that was something to do with the eyes. But then actually, like, I personally find that when I'm like, oh God, I look so tired, it's more to do with, it's kind of my like cheeks downward, and it's more to do with like my nasolabial lines, or like the fat pads in my cheeks, I feel like is sliding down my face. Do you know what I mean? Like, it's not, I think when someone says that they feel like they look tired, they might be surprised when you say, oh, well, actually, we need to treat kind of under the eyes.
Yeah, so I mean, what does looking tired look like for people? I think you've just hit the nail on the head. It's different for different people, isn't it? My looking tired is, I get sort of, you know, my upper lid gets a little bit heavier, particularly on one side. As we all age asymmetrically, I find one side it droops more than the other when I'm tired, for instance, or you know, finding that my tear trough is a little bit more obvious. And like you say, in other people, it's more that they feel that their whole face is feeling a bit heavier, and they're noticing their jawline's not quite as sharp as it used to be, and that's making them feel like they look older and tireder. And I think the important thing with aesthetics generally is the kind of the physical kind of attributes of emotion, which is what really we're seeing with aging, and what bothers people the most. It's not actually that they look older necessarily, it's those kind of emotional attributes that are associated with the anatomy of aging, I think, is more of an issue for most people. But yeah, like you say, I think actually what I find often with, particularly with the periorbital region, is a really common place that patients lose volume, but don't realise that it's affecting sort of around the eyes in the temporal region. So temporal hollowing is a really, really common thing I'm finding that is affecting particularly the sort of the lateral superior orbital rim. You know, you get an almost collapsing of that lateral brow, and the lateral canthus loses support, and so you get a more negative vector there. And I think it's not something your patients are ever going to come in asking for or realizing that they need, but I'm definitely noticing from consultations that I've been doing that is something that I think is a priority for a lot of people. And like you say, it's something that, you know, looking tired, actually sometimes a really easy and common fix is to treat the sort of aging temples. It's the fat and the muscle loss in the temples are what causes that hollowing. There's hardly any bony resorption there, actually, which I think is a bit of a misnomer often, and so replacing that superficially with a sort of a malleable and low rheology, low G prime filler. I personally like using RHA2 by Teosil, but there are plenty of other brands that do a great low G prime filler to you know, between layers 1 and 2. And just replace that volume, and it's a really lovely. It often gives you a really lovely. I don't like the word lift. It doesn't lift, but it gives a nice positive vector often to the lateral brow and the lateral canthus, and then can improve the sort of, you know, opening that eye space before you even go on to treat things like tear trough or palpable malar groove or even the midface. Like I said, you know, approaching from top to bottom is kind of how I work. and I find that because a lot of what you do at the top then informs the bottom, actually, you know, temples are often a really good place to start if it's appropriate. But I mean, other things in the mid-face that, like you say, things like replacing, you know, medial cheek fat, the soothe, so the fat underlying the lateral orbicularis oculi muscle. A patient's never going to come in asking for that. You know, you've got to be the one that looks at that face and goes, okay, you know, I've got to understand my anatomy of aging. What is it that happens when around the eye ages? And we know that there is bony resorption in the orbital rim. So you're going from having a sort of oval, sort of round shape out to often like a lateral aviator, sort of, you know, aviator rim deformity. So being able to treat that palpable malar groove as well as treating things like the tear trough is really important. And if you don't replace the soothe and the medial cheek fat, the deep medial cheek fat, before you do that, often your results won't be sort of as obvious. And you know, if you're looking at the vector on profile of the sort of, you know, draw a line down from the lash line through to the medial cheek, you know, if the medial cheek's flat or is negative, actually, you know, you're going to do them a disservice by just treating the under eye, because you know, that's when you start getting sort of puffy looking tear troughs, because you've not replaced that sort of, the confluence is lost and you've not replaced that medial cheek fat. So it's important, like you say, to not treat necessarily what the patient wants you to treat, but understand the anatomy of aging and sort of replace volume loss where necessary. So yeah, so and I'm finding that's a really, really common thing, and you know, often it's really tricky to sort of, you know, patients often get really het up with having their tear troughs treated because they've seen it on TikTok or Instagram, and you have to explain to them, actually, okay, that's one thing that's causing you to look tired, but actually if we don't treat X, Y, and Z, then you're it, you know, it's not going to help. And yes, it will be a bit more expensive than you're expecting, because we are having to treat multiple areas of your face. So it's kind of about managing expectations, I think, with patients. It's a really important part of the consultation.
I just wanted to show this. Oh no, hold on, can you see my screen here?
Oh yeah,
I just wanted to show this tear trough picture. You could kind of talk us through what you've done here.
Yeah, so this, it's a bit of a shame actually that this you can't see the sort of wider view of the temples as well, because this young lady, I did actually treat her temples as well, but for you know, so that I can anonymize the pictures, she was happier for me to show the actual just periorbital region. But here I have, as you can see, replaced volume in the medial and lateral soothe, which you can just about see, lateral soothe sort of there, and the deep medial cheek fat. For that I used 0.3 mils of ultra deep in the deep medial cheek fat, and 0.1 each in the medial and lateral soothes on each side. And I personally like approaching that treatment with a cannula from sort of 2 centimeters lateral and inferior to the lateral canthus. So then I can generate a flap by pinching the top layers of the skin and the muscle, so I know that I'm going underneath into that deep compartment, and replacing that with some boluses with a cannula. It then means that I can sort of, you know, I've got an entry point then to treat the tear trough and the palpable malar groove afterwards with, I use Redensity 2 to do that. But you know, by having one entry point that I can access all of those areas, I find there's much less downtime. Patients find it pretty comfortable. And I find I get a really good natural result, because you know, you know where you are, you know you're in those deep compartments. So I've used here Redensity 2. I actually used 0.5 on each side, which isn't a huge amount really, but if it's placed strategically, then actually you can get away with not using a huge amount in the actual tear trough and the palpable malar groove. if you have replaced that medial cheek fat and the SOOF volume sufficiently. So yeah, so this young lady is 32. She has a really busy job. She runs events, so she does long hours, and she's very, she's a Fitzpatrick type 1 fair skin, so you can see she's got classical sort of thin pale skin that you can just see that underlying vasculature and muscle, and just by correcting that light reflex, it's made a huge difference to her under eye. And she was delighted. She'd never wear, she's not someone that likes to wear a lot of makeup either, so it's quite nice for her that she can literally roll out of bed at 4 a.m. to start planning for these events that she's doing, and not have to wear any makeup. So for her, it's really given her a big boost in confidence. She's photographed quite a lot. So
the color, I was going to ask, like, where the color correction comes from. Is it literally because what was once a shadow, you're kind of then plumping out?
So for her, there's lots of reasons that you can have dark circles. For her, it was, like you say, it was an anatomical deformity, and she had fair, thin skin. So the darkness that you see with her is a light reflex largely, and also vessels that you can see quite easily under the skin. So just by changing the way that the light bounces off the skin, it changes the color of what you see. Now, that's not appropriate for everybody, particularly in darker Fitzpatrick skin. I actually was chatting with Sabrina Shah Desai a couple of days ago, and we were talking about the intricacies of having to do a really, really good treatment consultation, particularly with darker Fitzpatrick types, because there's a lot of different causes of dark circles. You have there's pigmentation from either sun damage or from ethnically, genetically being predisposed to having just a different color under the eye, and if you're going to, if you're inexperienced, or if the patient is really desperate to have tear trough filler but doesn't understand that actually a lot of that dark circle isn't being caused by an anatomical deformity, then the results you're not going to get the results by just treating it with some under eye filler. So for people like that, you've got to be really careful to manage their expectations. It's much more appropriate to counsel them on use of SPF, on skincare, so use of brightening products, vitamin C, arbutin in some cases, and retinols if appropriate. And make sure that they're not using anything that's going to irritate the skin under the eye, because it's really delicate, it's really thin. And by rubbing the eye, by using sort of makeup that irritates the eye, even some retinols that make irritate the skin around the eye, you're then kind of predisposing them to potentially having some post-inflammatory hyperpigmentation, which is then extremely difficult to correct. So yeah, with those types of patients, we're talking about kind of non-injectable treatments, really. But yeah, so patient expectation management, and really good thorough history and examination is really important for the under eye, I think.
Cool. Okay, so let's move on to the mid face.
Yeah, so mid face, we sort of covered a little bit about mid face and correcting particularly deep and superficial fat pad redistribution. So one thing I think really bothers people, and you just suggested it actually earlier, Georgia, is the nasolabial folds, and they're a tricky one, because actually as we age, it's very difficult to avoid nasolabial fat pad augmentation. Sadly, it's something that happens with age. The anatomy of the fat changes a lot as we age. Some fat pads get smaller, as we've already spoken about, and some get bigger, and the nasolabial fat pad's one of the ones that gets bigger. And so you start to see this sort of heaviness around the nose. That's then exacerbated by the maxilla protrudes as well as we age, so we lose bone, and so we lose projection in the sort of alar of the nose, which again just exacerbates that kind of like crease heaviness. So again, treating those areas really is about understanding the anatomy of the aging face, not just anatomy, but anatomy of aging. There's a difference. So things like restoring volume of the alar here, and you know, often this sort of heaviness at the nasolabial fat pad is exacerbated by flattening of the medial cheek fat. So often replacing medial cheek fat then gives you a little bit more confluence here, so this isn't such a prominent feature. And then I tend to try not to treat the nasolabial folds directly until the kind of last moment, really. So often restoring mid-face volume loss to give a bit of support can be a really good way of again, it's a lot about light reflex. It's a lot about, you know, encouraging people's eyes to look at a smooth, confluent, plump mid-face rather than a shadowed nasolabial fold. So, you know, treating the pyramidal fossa is something I do quite a lot of, rather than the fold itself, because really you want to be treating the sort of cause of the symptom rather than treating just the symptom, which I think, you know, in the last 5 years, our mindset around treating particularly things like nasolabial folds changed quite a lot, and the general consensus actually is rebuild the volume loss in the mid-face first before sort of treating the folds directly, for a much more natural result. But again, it's about expectation management, because a lot of patients will come in and all they want is for you to fill these folds, and you're there sort of going, well, actually, you know, I can do that, but firstly, it probably won't smooth out as much as you want to, but also it can end up looking quite bizarre. You know, obliterating these is a no-go, actually, because, you know, babies are born with nasolabial folds. It's just they've got a bit deeper as you've got older. So having completely smooth you know, transition here would look very odd, but people get fixated on it, and I think, you know, because of all these Zoom calls and things, we're looking at a bit of Zoom dysmorphia, I call it. That's not an official phrase. But it means that people are really picking holes in their appearance, and a lot of what I'm saying to people is actually, you know, it's firstly, the Zoom call is the worst it's ever going to look like. It's so unflattering, you know. You're using a camera lens that's not really designed to flatter you, and you're fixated at looking at these areas of imperfection, and actually, you know, it's take a step back and kind of look at the bigger picture and think, well, actually, you know, how much actually is this an issue for you? Because you know, personally, as someone that looks at face every single day, I don't think it's that bad, you know, and just sort of reassuring people that they don't have to look perfect, even though Instagram and TikTok sort of suggest they should. And actually trying to get, you know, if you're aiming for that perfection, firstly, you're almost always going to be disappointed, and secondly, actually, people start looking very weird and kind of almost airbrushed, which I don't think actually is a particularly healthy thing that us as practitioners should be encouraging. So again,
I imagine you might be finding that more with perhaps if you're seeing a lot of new patients who haven't had a set of treatments before, coming in and saying, like, they have been kind of just nitpicking their face and they've zoned in on one thing that they're like, I want that treated. And I imagine you might find that more having to manage expectations more with someone who perhaps hasn't considered a treatment at all before, but all of a sudden they've got this massive problem on their face that they need sorting.
Yeah, no, you're so right, absolutely. And I think the other thing that people worry about is always being addicted to the treatments. You know, and they sort of go, well, I've always kind of wanted to do something, but I'm worried I'm going to get addicted. And I'm saying, well, actually, you know, firstly, you're in the right place. I'm not going to let you have treatments that I don't think that, you know, are necessary. But also, I think, again, it's about that kind of listen, the one thing I really don't want you to do is chase perfection in your face. You know, actually, we're really blessed to be able to age. Looking older isn't a bad thing necessarily. And yes, of course, there are little things that might bother you, and that's fine. And we can try and refresh how you're looking. But actually, we're not looking to get your under eye looking completely perfectly smooth, like an airbrushed, supermodel. It's just, you lose character in the face, and actually, you still want people to look themselves. I think that's my personal opinion on sort of my approach to aesthetics. So yeah,
I wanted to just have you talk through this. I've got a couple more images here, and one particularly of this liquid facelift. Because that kind of incorporates a lot of the mid, but also the lower third. And this result is really impressive. So I just want people to see this. If you could just talk us through what you did here. Hold on.
Sure. Yeah, so this lady is so lovely. She's a dog walker. So she spends a lot of time outside, and she noticed sort of, through the menopause, that she'd aged quite significantly over quite a short period of time. And I think, again, that's a really common problem that people seek help for. So this lady kind of exhibits, if you look on the left-hand picture, a lot of those sort of the traits that we were talking about before. She's lost volume to a certain degree in the temples, although you can't see it particularly well on this oblique view. She's lost periorbital volume. She's got that A-frame deformity, so her palpable malar groove is very obvious. She's lost fat in the souf. She's lost fat in the deep medial cheek compartment, and the other thing which we haven't touched on is she's also lost superficial lateral fat pad as well. So I used, I think, about 6 or 7 mils on this lady. It was quite a lot in one sitting, but it's quite nice to be able to show this before and after to patients, because I think people worry about having really unnatural results with a lot of filler, and actually this is a lot of filler. 7 to 8 mils is a lot in one sitting. It's not something that I usually try and do, but we did do it in this lady, and so we replaced. We started again top to bottom, so replace a little bit of the volume loss in the temporal region, the medial cheek fat, deep medial cheek fat, the souf, the tear trough, and then I also did I replaced a little bit of loss of volume in the zygoma laterally. Actually, contrary to sort of popular belief, you don't lose a huge amount of volume from your lateral zygoma with age, but I think sometimes it is quite nice just to replace, just to sort of highlight the cheekbone, because it just if it's appropriate, it brings quite a nice natural light reflex to that area, and again just gives that nice sort of subtle confluence with the OG curve. Also replace the lateral superficial fat here, another of the fat pads that loses volume with age, and actually that can give a really nice support to the sort of lower face by replacing some of that. And I find often actually that softens nasolabial folds indirectly, and it also can soften that kind of jowling that you see. So we did that first, and then reassessed, and then actually I approached the perioral area next with, I like to use, I use a 50mm cannula for a lot of what I do. I mean, I know that's quite long for a lot of people, but I find it means I don't need to use so many entry points. So for the lower face here, I've done an entry point sort of, as you can see, just about in the sort of jowl there, and have replaced the perioral fat underneath the lip. You can see there in the labial mental crease, and have softened that sort of marionette line again just by just replacing some of that fat that's been lost. And then from that same point, I've gone into the chin and just extended. You can see sort of from that oblique view that I've just brought her chin down and forward a little bit, again, just to replace some of that bony resorption that you see in the chin and the jawline. And then from there, I tend to then sort of reassess and then look at the jawline itself. This is an area that can take quite a lot of filler if you're not careful. So, you know, replacing all of that volume above the jawline is really, really important, I think, to sort of soften that jowling as much as possible, from where you can see that like medial cheek fat descent. You know, it can be a really tricky area to treat subtly and well. And again, managing expectations of patients for this is really key, and getting them to understand that actually you're not going to be lifting that, so to speak, unless you're going to be doing either thread lifts or a surgical intervention. But what you're trying to do really is kind of mask it and draw the eye away from that heaviness. So by replacing the sort of perioral fat and augmenting the chin, it softened that slightly, and then I've gone into the jawline itself and replaced some of that bony loss, kind of where you can see the dip on the left hand side, just where the marionette line is. And actually, she had a really great result. She's a really great patient to treat with something like this because she's quite slim already. And so things like the medial cheek fat descent and the sort of laxity of the mandibular ligament there aren't as bad as someone that's maybe got a little bit more fat in their face. So actually, really for her, it was about revolumizing a lot of the fat loss, really, rather than disguising the sort of the fat hypertrophy that a lot of people get in their 50s. But yeah, pan facial treatment's always really satisfying, but you have to be, again, you have to counsel them and manage their expectation of results. You can't get a result like that on a lot of people, I'd say. And you know, using a lot of filler can scare a lot of patients. So I think, again, just having a really good pre-treatment consultation is really important for people like that.
Yeah, absolutely. Cool. Okay, well, before we wrap up, I just wanted to ask you quickly to just talk about submental fat and what your approach is to that, whether you will kind of address the fat directly, or you'll kind of approach it through the jawline with filler, for example. And I think that's definitely something a lot of people are going to have complaints about now.
I completely agree. Yeah, to be completely honest with you, it's really patient dependent, and there's a lot of reason why people get a heaviness under that submental area. Some of it, like you've alluded to, is because they've lost structure in the jawline, and maybe they've got sort of agnathic chin. Sometimes just by simply, if the submental area isn't really heavy, sometimes just replacing the volume loss in the jaw and chin can really help just support that skin underneath. Other patients need treatment directly into the neck to tighten skin, so things like skin tightening treatments, radiofrequency microneedling, Profilo, even, combination of treatments to help with skin laxity. Again, sometimes will be enough just to sort of soften the appearance of that and give that skin some support. If there is, and again, it's about really good clinical examination. If there is a lot of submental fat, then yeah, things like fat reduction treatments, either injectables such as Aquilix, or energy-based devices such as CoolSculpt, can be options for the fat itself. But again, you've sort of got to view it from a holistic point of view, and often it's a multimodal treatment for me. I'm often doing a combination, and it can take a little while to get to where they want to with this. But yeah, it's like I said, it's pretty patient dependent, and a lot of it will go on your history, managing expectations again. And the examination is really key, I think, with the submental area. I'm actually really quite standoffish with lots of treatments, and actually, if I think that they're not going to get a really decent treatment with non-surgical interventions, then I just say to them, to be honest with you, I think this is a surgical treatment. And I think I'd really encourage practitioners to, if you're not used to surgical treatments, maybe spend some time with plastic surgeons to understand what interventions are available surgically, so that you have that spectrum knowledge, so that you can make informed you can inform your patients so that they can make informed decisions, because there's no point in really trying to get rid of this very bulky area if it's just not going to shift with non-surgical treatment. So if it's significant, then often I'll just refer to trusted plastic surgeons.
Cool. Okay, well, we're gonna have to end in a sec, but first of all, a question for you. So is there anything additional to consider with patient care, thinking about perhaps more of the mental health factors that come into play throughout lockdown? So things like, I guess, anxiety or stress, and whether or not that may have affected their desire for treatment. That must be such a fine line between someone coming and saying, I've noticed this and it's bugging me. Like that must be a real fine line between that and then considering whether or not someone perhaps has body dysmorphia.
Absolutely. That's a really great question. I'm so glad someone's highlighted that, because you're so right, it is so important. And as aesthetic practitioners, we really need to take care that we're not treating people inappropriately. Body dysmorphia obviously is one end of the spectrum, but actually it is a spectrum. And I think I'm really careful with who I do and don't treat. From a selfish point of view, it's just not worth it. I've made that mistake early in my career of treating someone that I shouldn't have done, and I'm very honest about this with people. And when I'm mentoring students and when I'm mentoring people coming through, I tell them, the worst thing you can do is treat someone that shouldn't be treated. So part of that comes with experience, I think, and making mistakes like I have done in early in my career. Part of that is, do courses in the psychology of aesthetics, understanding, be able to diagnose BDD, and not just be able to diagnose it, but who then are you going to refer to? If you're not in a really good network within with a wider clinic network, it's really important that you do make connections with trusted psychiatrists. I've got a wonderful colleague that I use who's a GP, but she sort of specializes in sort of psychological input and mental health. And so I'll often, if I'm worried about someone, or I think, well, do you know what, I understand that you want this treatment, but actually I think maybe there's a few things you need to work through before coming back, then and referring them to someone that you trust that can take care of their mental health. And then I think the other thing is always give them time to think about things. I think often these consultations, you give them a lot of information, and it's very easy for them just to jump into something. And like you say, sometimes that's just not appropriate. And I'm not afraid actually to send people away and say, listen, I want you to go away, think about this. I've given you lots of information. I think perhaps, it's something you need to think long and hard about, whether you actually really want to be doing this, or whether there's something else that's bothering you, underlying that's bothering you. And I'm happy to see you in 2 weeks' time and we can chat a bit more about it. And then often I won't even treat them then. And, it's about that sort of, like you say, it's a fine line, but it's about that sort of personal assessment of that person, really talking through why they've come to seek treatment, how long have they been thinking about it for. If it's a snap judgment from their part and they only started wanting this treatment last week, then perhaps they need to go away and really think about how much they really do need that treatment or want that treatment. A cooling off period for patients, I think, is really key. But yeah, I'm in agreement with you. I don't think that's necessarily like a right or a wrong threshold for it. I think it's pretty individual, and it's sort of to some degree comes down to individual judgment.
Okay, well, thank you. We're going to have to wrap up now, but that was really interesting. It was great to get some of your expertise and talk through some of your before and afters, and I hope that everyone found that useful. And is excited to start treating again next month when we'll get back to business. So thank you so much for that.
No problem. It's lovely. Thank you so much for having me and taking time to chat. It's been a really nice way to spend my Thursday afternoon. And if anybody has any other questions, then I'm very, very happy to answer people's questions. I can share my Instagram or email.
Yeah, let me know your Instagram and I'll pop it in the chat box.
Oh, perfect. So it's at Dr._Denning. Oh, sorry, Dr. Denning, no underscore, and then underscore cosmetic doctor.
Okay. What, cosmetic doctor is like one word?
Cosmetic _ doctor.
Okay.
I've just changed it, which is why I can't remember it.
No, that's right. I didn't know the aesthetic medicine one for ages. That's fine.
The Dr. Denning bit is DR rather than doctor as a word.
Okay, let's try again. And also do have a look at Dr. Denning's article on, hold on, Dr. Denning _cosmetic _ doctor.
That's it, yeah.
Do have a read of Catherine's article as well on the aesthetic medicine website that she wrote all about lockdown face for the March issue. Thank you everyone for watching. Thank you, Catherine, that was great, and we will speak soon.
Lots of love. Have a great afternoon,
Thanks
everybody.
so much. You too.
Bye. 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 Bye.